sorry. طيب, I'm going to be talking today about evaluation of pigmented lesion, actinic keratosis, and SCCs. I threw in BCCs as well. I mean, it's a broad topic, a topic that includes, dermoscopy, includes a lot of treatment. So I tried to simplify it. And again, we'll keep it as a discussion and we'll make it both helpful and useful for practical lesions and for residents, maybe for board purposes as well. So this is me, have no conflict of interest. And I don't know if you guys know this guy over here. Does anyone know him? Maybe Houriah.
Dr. Anderson.
Yeah, Rex Anderson. He's one of the nicest, most humble people I've ever met. And he's the guy responsible for all the lasers that we use in dermatology basically today. From, pulse dye lasers to hair removal to picos to, you name it, Fraxel, cool sculpting, everything. So I had the pleasure to do my fellowship with him, and he's a great mentor. So approach to pigmented skin lesions. So like anything in medicine, let's see, do people want to chime in? Let's say a patient comes in and say, hey doc, I have a spot over here. What would you ask? في أحد يبغى يشارك؟ No? Okay. Then we'll just continue. So لما يجيك مريض يسألك اوكي دكتور انا في حبة هنا تغيرت، تقول له كيف تغيرت؟ مثلا كبرت، صغرت، تغير لونها. symptoms هل فيها مثلا does the patient complain of any symptoms, bleeding, ulceration, itchiness, any lesions after 50 you should be wary of. Family or strong history of melanoma, personal history of melanoma as well. If a patient is, a certain phototype, skin type 1, 2, with a strong history of UV exposure, you ask about also if there are any medications they're on, especially immunosuppression, and we'll see why. When you examine the patient, we all know the ABCDs of melanoma. So A is for asymmetry. So if you fold it on itself, it doesn't fold perfectly. Irregular borders. We like nice and smooth borders, not ragged or sharp borders. Color variety or color consistency is important. For me, this is one of the biggest signs. We call it variegation in color. So when you see different shades of color, that should be concerning. Diameter, not so much. I don't agree with the size per se. It's the increase in size that is more concerning. يعني مو مهم لو قال لك دكتور هي كبيرة ولا صغيرة، لا بس لو قال لك بدأت تكبر, that's concerning. And I think this is the biggest rule of thumb over here. It's when you examine a patient, look at all their nevi or look at their rest of their skin. If something sticks out as the ugly duckling, definitely, be concerned and maybe consider biopsying it. Because you'll see patients, they'll make funny molds all over their body. Everything is asymmetrical, everything. So you cannot biopsy everything. So if you get a sense of how their body is making their nevi. So if something is sticking out, it should raise a red flag and just take a better look at it. So what could it be if someone shows you like a pigmented lesion? It could be something benign, melanocytic nevi, whether junctional, compound, dermal. It could be in between. So it could be dysplastic, meaning it's neither completely normal or completely malignant. And a lot of histopathologists, they will stratify the degree of dysplasia. So they'll tell you it's mild to moderate, and severe. So the way we do it, mild, we kind of ignore. Mild to moderate, we follow up. So we'll tell the patient to come in a year, and then we'll take another look at it. Severe the dysplasia, we usually excise. So we excise it as if it was melanoma in situ. The other differential could be melanoma, of course. There's many types. There's superficial spreading, there's nodular, there's lentigo maligna, and amelanotic melanoma. Could be non-melanocytic. So sometimes you have pigmented SKs that can, trick you. Pigmented BCCs, lentigos, of course. You can have pigmented AKs. So all these have pigmented variations, and they can be tricky. So with experience, and dermoscopy can help as well. So let's take a look at some dermoscopic examples. So this is a superficial spreading melanoma. Okay. So without a dermatoscope, you can see right away. So it's not regular. The borders are not smooth. Okay. There's a ton of color variations. Okay. So even if you know zero about dermatology, this should catch your eye and be concerned. Regardless, what we see is we see some streaking. This is also a big telltale sign, the blue-white veil. Okay. You can see some globules. The pigment network is not regular, and you can have negative networks as well. So you'll have positive and negative networks. This is a nodular melanoma. Again, without knowing anything about dermoscopy, this should catch your eye as something concerning and would consider biopsying. You'll see these polymorphous vessels, and you see these blue-black pigmented areas like in the middle. This is a little bit more tricky. So this is lentigo maligna melanoma. And lentigo maligna, by definition, is melanoma that arises in sun-exposed areas. Usually they're thin, broad, and you find them in the face or other sun-exposed areas. The telltale sign is circle in a circle. So you see a circle in a circle, circle in a circle, plus the other signs that we talked about, like the color variegation. So you'll see like areas of over here, there's loss of pigment network. It's definitely not symmetrical, and it's irregular. This is probably a dermatologist's worst nightmare, is amelanotic melanoma, because it can be easily missed. It looks like nothing, like a pink spot. And it's really, really hard to pick up on exam or even on dermoscopy. One of the things that you can see is these dotted vessels and over this pinkish background. But to be honest, they're really hard to pick, and you can miss them easily. So hopefully you can pick them up with good dermoscopy. This is probably more relevant to our patient population. So we'll see more acral melanomas, right? Rather than your typical melanomas that you see in Europeans or lighter skin types. So when you examine acral melanomas, whether on the palm or the feet, okay, you look for furrows, okay? So the way I was taught, furrows are friendly. فلما تشوف البيجمنتيشن هنا في الفurrows في الخطوط وهنا الإيكراين glands are spared, this is usually reassuring. Okay, so furrows are friendly when you see them on this dermoscopy. على النقيض, when you see furrows lack of pigmentation, والعكس اللي قاعد يصير إنه الإيكراين glands are involved, this should be concerning, and you should definitely consider a biopsy. Okay. Again, I don't know if there are some residents here or some like board fodder. So mucosal and acral lentiginous melanomas are usually associated with KIT genes. So they ask that on boards. And uveal melanoma are associated with GNAC and GNA11. Again, maybe more for residents who are taking boards. There are a ton of familial melanomas. CDKN2A is the big one. You just know the pathways, know the association with pancreatic cancer. When do we do genetic testing? Usually people who have 3 primary melanomas. مثلا جاك patient 1 2 3 يجي يسألك دكتور طب هل أحتاج أسوي genetic testing؟ إذا عنده 3 primary melanomas, yes. 3 cases of melanoma first degree, 2 cases of melanoma, and 1 pancreatic cancer in the first degree, and so on and so forth. Again, they may or may not ask that. Multiple nevi, people who have like a ton of nevi everywhere, that could be syndromic. Strong environmental factors, immunosuppressions. We don't usually do genetic testing, but transplant patients have about a 3-4-fold risk of developing melanoma. And that could be relevant to our patient population because we don't see melanoma that often, but in the immunosuppressed population is more common. Again, what are other tools that we can use to help diagnose pigmented lesion? Let's say you have a patient who comes in, they have a huge lentigo, half their cheek, and this is a real patient, by the way, half their cheek. What are you going to do? You can't biopsy the whole lesion. What you can do sometimes is biopsy scouting lesions, do multiple, and then again, you're not evaluating the whole lesion. So we have something called RCM and something called OCT. So if you consider your eye is 1x, a dermatoscope is 10x, a confocal microscope is 100x. It magnifies to the cellular level. So you see cellular detail. Okay. الفرق بينها وبين الhistopathology is cut vertically versus RCM or confocal microscopy is en face or horizontally. So you have to switch your brain to look at it and en face rather than vertically. Plus, you don't have the staining, so it's black and white. However, we do have another thing called OCT, optical coherence tomography. And OCT gives you cuts that are horizontal, okay, that are vertical. So it's exactly like what you see in histopathology. The only sacrifice is cellular quality. So you don't see the cells as clear as with the RCM. So you can go deeper. It's also the same orientation, but the quality or كيف أقولها يعني you don't see the cellular detail. Okay. Let's move on to AKs. Okay. So AKs usually they're super easy to diagnose. Honestly, clinically, you feel them more than you see them. So they feel as these like rough, gritty, pink papules. Okay. Happens in sun-damaged area on the face, on the arms, on the legs. Does anyone know the risk of transformation into SCCs? Because we call them, pre-malignant lesions. Does anyone know? ما أعرف أنا إذا موسى معكم ولا nobody wants to chime in. طيب. So these are AKs, like I said. I'll go back.
في حد جاوب دكتور سعود إنه ال risk of transformation to SCC UV light causes DNA mutations and keratinocytes.
جميل. بس what الريسك؟ كم transformation? It's 1 in 1,000 per year.
Okay.
So it's very, very low. So we call them pre-malignant, and patients get concerned. It's like, oh my God, doctor, I'm going to get cancer. No, it's exceedingly low. And do you guys know which type of UV causes skin cancer? UVA, UVB.
Okay, هنا في حد جاوب برضه دكتور from 0.1 to 10%.
Yes.
Okay.
I wouldn't say 10%. 0.01 is probably
0.01.
so like 1 in 1,000.
Mm-hmm.
So There's two types of UV. There's UVA and UVB. UVB, just for you guys to remember, is the bad one. Okay, B for bad and can give you cancer. UVA is more associated with, aging, elastosis, stuff like that. طيب, how do we treat AKs? We usually treat them with cryotherapy. Okay, just liquid nitrogen. We spray them 5 to 10 seconds. That's the easiest way to do it. Sometimes patients are covered with AK. When I say covered, they're covered. They have hundreds. So it's not feasible to treat them all. So the alternative is to do something called field therapy or field decancerization. There's multiple ways to do it. There's things like imicumod, there's 5-FU. So those are creams that you put and they trigger your immune system to attack these sun-damaged cells. So imicumod is a toll-like receptor. I think it works on number 7, and it triggers a Th1 response to remove these sun-damaged cells. 5-FU is a pyrimidine inhibitor. If you guys remember your, I don't know, biochem, uracil. So it stops DNA synthesis, so it kills these cells. Another way of doing it is something called photodynamic therapy. Okay. Photodynamic therapy is you introduce a photosensitizer to the skin. يجيك المريض كنا نسويها كثير يعني في أمريكا. يجيك المريض مثلا he's covered his hands, his face, فنحط له مادة اسمها ALA, aminolevulinic acid. هذه تتحول inside the cell into protoporphyrin 9, sensitize a cell to light. Usually what we expose them, either blue light, like in the 400 nanometer, or red light, which is slightly better because red light is in the 630, I think, nanometer, and then it goes deeper into your skin. So it can even hopefully remove not only actinic keratosis, but maybe squamous cell in situ, etc. في حد عنده أي سؤال عن الأكيز؟
Okay, so far بس they're answering معك دكتور. فأماني بتقول 5-FU photodynamic therapy. So في الشات أنا بس I'm just reading the chat for you.
good. طيب خلينا نرجع. نسيت أتكلم عن التريتمنت. حابين نتكلم عن كده بسرعة عن التريتمنت الأوبشنز للميلانوما.
أوكي حلو. ممكن يعني كده ناخذ كده quick review عنها.
طيب عندك كده الديسبلاستيك اتكلمنا عليها صح؟ So mild we leave, mild to moderate we monitor, severe we excise. Melanoma in situ, meaning melanoma with zero invasion, هذه we excise, usually with a 5 millimeter margin. You can do Mohs to it as well, but most people excise it. If it's invasive, depending on the stage, so we won't go into staging, and I think it's beyond the purposes of this lecture, but stage 1 and 2, you can do a lymph node biopsy. So you send them not only for excision, but for a lymph node biopsy. And stage 3 and 4, you can do elective lymph node dissection, sorry. Having said that, there's debate on the benefit of the lymph node dissection. So it did not increase life expectancy. However, it did decrease the disease burden. I mean, so they lived the same time, but disease-free, if that makes sense. So that's basically it. If they're non-operable, there are options to use, especially for melanoma in situ. You can use, again, imicumod, 5-FU, you can use radiation, etc. وحتشوف كثير من الأشياء بتتكرر. طبعا إذا metastasized, okay, then we talk in the realm of immunotherapy. So بداية الميلانوما كان في two teams, targeted therapy and immunotherapy. So they target things like BRAF, KIT. بعدين تطورت العلاجات صارت immunotherapy. فبدت أشياء زي ال PD-1 inhibitors وغيرها. And immunotherapy definitely won the battle. They're by far more superior. لأنه when they targeted البيراف إيش اللي صار؟ صار الميلانوما cells they actually mutated. صار في escape pathway. They do help initially, but then they lose their efficacy with time. Anyway, so just know about immunotherapy.
Okay, perfect.
And again, for the residents, just know لأنه يسأل السايد effects وكذا.
Okay, perfect. دكتور سعود بس في question، هل تحب ناخذها الآن ولا نهاية المحاضرة؟
لا بالعكس أحسن، أحب discussion كذا.
تمام. ففي question من دكتورة أماني. She's asking, Doctor, if we suspect AK transformation to malignant SCC, we take biopsy first, then treat as SCC. How do we treat it in brief?
No, I mean, if you take a biopsy, wait for the path report. So the way I treat AKs or equivocal AKs يعتمد على المريض. مثلا مريض والله عشان كذا لازم يكون بينك وبين المريض ريبور. مريض very anxious ما عمره جالس سكين كانسر، دكتور أنا مرة خايف، مثلا عندي هذه it's bleeding وأنا ماني متأكد يعني it's probably an AK but I'm not 100% sure. I would biopsy it. Okay. نفس البيشنت لو جاني مثلا جت له ما شاء الله في بيشنتس عنده هذه 10 SCC وخامس BCC. hey doc it's okay just give it a hard freeze. فبعض الأحيان I treat it symptomatically. أعطيها مثلا هذه الإكويفيكال بدل ما I freeze it 10 seconds بالكرايو I freeze it 15 seconds. I give it a harder freeze وأقول له تعال بعد 3 شهور to see if it's gone or not. Most of them they actually do disappear. And even if it's an early SCC, a non-invasive SCC, cryo does work actually if you hit it really hard.
يعطيك العافية دكتور. So far في one question إن شاء الله، الحين ممكن مع باقي السلايدز كذا إن شاء الله يعني.
Yeah. Also another يعني how to في study طلعت في New England Journal of Medicine a few years ago. Well, no, not a few, like الحين. It's been a while. What are the things to help prevent AKs, especially, and possibly non-melanoma skin cancer? Niacinamide, so 500 milligrams a day is helpful. Like patients with high risk of skin cancer, we put them on something called acitretin. Acitretin is like isotretinoin, okay?
Okay.
We rarely use it in dermatology in the specific areas, things like RPR, whatever. But acitretin can be used in as a chemo prevention for skin cancer for patients with recurrent skin cancer. And the reason we don't use it a lot, لأنه stays in your body forever. It stays 6 months. So I would never give it to a female. حتى لو حلفت بالله قالت إنه she won't get pregnant. It still stays in your body for 6 months. Anyway, so acitretin is one of the things that you can use as a chemo prevention. Also, one of the things you'll see people who go on consults. I think we'll يمكن نتكلم عنها. خلينا نشوف. Treatment and risk of progression تكلمنا عنه. طيب. الشيء اللي بعده ممكن يصير بتتحول من AK ل SCC. قد تكون in situ قد تكون invasive. On dermoscopy you see the classic hairpin vessel. تعرفون الهيربن يسمونها توكا. شفتوا هذا اللي هنا؟ شوفوا الماوس ولا مو باين الماوس؟ كأنها توكا صح؟
أيوة نشوف الكيسر.
كأنها توكات صح؟ فالهيربن vessel هذه كلاسيك وفيها السيربنتاين vessel as well كأنها serpentine like a snake. Okay, so these are the clues in dermoscopy. Risk factors, UV exposure. وهذه مهمة cumulative long-term exposure. Okay, versus melanoma لا intermittent exposure. Indoor tanning, PUVA as well. We don't use it as much. In the past we used to do instead of narrowband UVB اللي هو العلاج الضوئي كنا نستخدم a photosensitizer called PUVA. ياخذ حبة والبيشنت ينتظر وبعدين we use the UVA. It turns out it increases your risk for skin cancer. I don't know if it's important or not. They may or may not ask in your boards, but like the magic number is 400. After 400 treatments, your risk increases significantly. And you can spot these patients right away. يصير عندهم شيء اسمه بوفا لنتيجينيز. اللنتيجينيز اللي هي زي الفريكلز اللي عندنا تكون مرة غامقة. So you can spot them right away. You're like, oh, you had pova? You're like, yeah, I had pova. But we rarely use it anymore. And you'll see this be أشياء, chemicals, radiation, tar, etc. I think this is also important to know. هذا الكل يعرفها اللي هي ال HPV subtypes 16 and 18. I would add 31 and 32 to this as well. What else? This is important. طيب كل ال SCCs زي بعض؟ لا. طبعا الهاي ريسك SCC غير اللو ريسك SCC. الانكريس تومر سايز اللي اذا كان حجمها اكثر من 2 سنتيمتر. لوكيشن مهم. high risk areas are ear, lip, genitals. The pathologist sometimes will throw in words like poorly differentiated, desmoplastic. Perineural is definitely concerning. Sometimes we send them for radiation treatment if they have perineural, and lymphovascular infiltration as well. Depth is important. 4 millimeters is concerning if the SCC goes really deep, and immunocompromised status. Recurrent lesion also is considered as high risk. مهمة عشان to define the way you treat it, whether with Mohs or with neoadjuvant, adjuvant treatment. Also sometimes there's something called appropriate use criteria. هذه للموز. When do we use Mohs? When do we don't use Mohs? مثلا جاء patient عنده a simple SCC ولا BCC على الchest. It doesn't just necessarily qualify for Mohs, okay? But if it's recurrent or if he's immunocompromised or لو جاء مثلا radiation on the chest area, so now they qualify to get Mohs because of the high risk features. في حاجة هنا اسمها Brigham and Women staging. ما أعرف إذا مهمة ولا لا، بس إنه ممكن يسألوكم في boards, but just know that there's a different staging system in addition to the AGCC staging system. They might ask you about, I don't know, ما أعرف إذا في البورد هنا يسألون TNM staging as well and the stage type. طيب lastly في أي أحد عنده سؤال عن ال SCCs قبل لا نرجع نمشي؟
So far I think في الشات ما في questions. هو كان سؤال ال SCC حق ال AK.
جميل. طيب BCCs. BCCs are probably the most common human cancer. It's exceedingly common. يمكن ما نشوفه كثير في السعودية، بس ما في عيادة في أمريكا ما فيها BCC. diagnosis مرة سهل. يعني حتى without dermoscopy, it's like this ulcerated pearly papule. You see what we call arborizing blood vessels. So that's the buzzword, arborizing. يعني كأنها متشعبة كأنها زي الشجرة. Okay. Sometimes you see these white blotches as well. So those are the clues. واضحة البي سي سي. حتى لو قارنتها بالباك جراوند فيسلز، في ناس يتلخبطون من الباك جراوند فيسلز. هذه غير هذه، صح؟ You see how they're more noticeable and arborizing.
صح.
Yeah, okay. طيب risk factors, same thing, fair skin, age, etc. same risk factors. فيه برضه سؤال يحبون يسألونه، كم الريسك قلنا في الاميونوسبريشن؟ قلنا الميلانوما 3 to 4, BCC maybe 5 to 10. بس ال SCC is ال SCC by far is you'll get more lesions with immunocompromised patients. Again, for the residents, just know all the syndromes that are associated with all of them with melanoma, BCCs, Gorlin, etc. Nevus sebaceous, there's a small risk. However, it's not the most common skin cancer. فدايما يحبوا يسأل السؤال ده في البورد. خلاص. طيب قلنا organ transplantation, yeah, 1 to 100. هذا برضه مهم for patient cares, especially people who are going to do inpatients or see inpatients. So you'll see a lot of patients on sirolimus, tacro, sorry. So tacro, cyclosporin, a lot of these immunosuppressants will increase your risk for skin cancer. So oftentimes we'll call the consulting team, and we'll tell them to switch the patient from tacro to sirolimus just to increase their risk of skin cancer. That's also a board favorite, CLL. أتذكر جاني سبحان الله في أشياء الواحد ما ينساها، معني أخذت البورد ما أعرف من الحين كم 7 سنين. حط لي إياها كلها AML ALL بس. CLL is the one that is increased risk. Organ transplants. طيب أحد يقول لي which organ transplant is the highest risk? Can someone guess?
دكتور إيش كان السؤال تاني؟
إيش؟
معلش بس قطع الصوت شوي. إيش كان الكويشن دكتور؟
إيش أكثر transplant patients يعني kidney, liver, lung, heart, etc.
Okay.
يجيه.
I think Sammy answered. ده بتقول renal.
It turns out heart.
Heart.
And the reason is simple. It's not because of the heart. It's because they have the highest immunosuppression. Does that make sense?
Yes.
Okay. Drugs تكلمنا عنها. What else? طيب هذه مرة مهمة. أصلا كيف يصير الباثوي حق البيزل سيل؟ اوكي. البيزل سيل في عندنا شيء اسمه جلي هذا يسوي ترانسكريبشن للدي ان اي. اوكي. اللي يكون ماسك شيء اسمه سوف. اوكي. اللي يشغل هذا كله السموذن. فالسموذن السموذن اذا اشتغل يشغل الترانسكريبشن. واضح؟ عشان شوي تلخبطه ممكن تكونوا معي حبه. السموذن يشغل هذا. الفرامل اللي هو البي تي سي اتش 1. اوكي. هذه الفرامل توقف كل شيء. فلما يصير ميوتيشن هنا كأنك رفعت الفرامل، سموذن شغال انهبيتد، السوفو والجلي بينزل ويسوي ترانسكريبشن unregulated، وبالتالي يصير بيزل سيل.
Okay.
This is really important لأنه التريتمنت are smoothen inhibitors. So فيزموديجيب وغيرها سموديجيب تشبك في السموذن وتنهبت كأنه يسوي شغلة ال PTCH1 اللي هو الفرامل اللي صار له ميوتيشن في وهذه اللي اكتشفها عالم بريطاني، واكتشف الباثوي. ايش سماها؟ كان يحب سونيك ذا هيدج هوج، لعبة الكمبيوتر هذه سونيك، وسماها سونيك ذا هيدج هوج. فاتس كولد سونيك ذا هيدج هوج باثوي.
البزماتشيب it blocks ال PTCH1 صح؟
لا سموذن.
اوكي.
Yes, it's smoothen inhibitor.
اوكي.
كأنه يسوي شغلة ال PTCH، يضرب فرامل. اوكي. طيب ايش الهاي ريسك ارياز او فيتشرز؟ تكلمنا عن الاس سي سيز، برضه مهمه البي سي سيز. طبعا يقسمونها ل 3 areas. لازم يعني it's not important. السايز is important. يعني مثلا قلنا مثلا في الشست is a low risk area. You don't necessarily have to do Mohs إلا لو مرة كبيرة يعني above 2 centimeters. في medium risk تكون في الوجه في أماكن حساسة، والhigh risk areas اللي هي الماسك areas, eyelid, ears, etc. You don't have to memorize it, but poorly defined borders, recurrent. هذه مهمة. Aggressive growth pattern. So the pathologist will tell you it's infiltrative, micronodular, morpheoform, اللي هي سكارينج تكون بيزو سكويمس سكلروزنج يعني، او انت حتى تشوفها في الموت. sometimes you get a run of the mill BCCs and you'll be like, whoa, it's infiltrative, it's micronodular, radiation sites, immunosuppression, and perineural invasion. Okay. What is the real risk of metastasis? Why do we treat these patients? It's super low. Okay, they rarely metastasize unless neglected. When I say neglected, I mean tens of years. Okay, the reason we treat them because they're locally invasive. They're erosive. لو خليت البي سي سي على مثلا النيزل ايلا it's gonna eat through it. حطيتيه على خليتيه في eyelid, it's gonna eat through it and maybe even go to the bone. So it's locally invasive versus doesn't necessarily metastasize as much as SCCs and melanoma. There used to be something called a hat sign. يجيك المريض لابس هات وما يبغى يفتح، أول ما تشيل الهات تلقى بي سي سي قد كذا. So they can يعني live with them, but it's locally invasive. That's what I'm trying to say. Okay, these are my references. Again, I don't know if it was too simple. There's a lot to cover. We could just spend the whole day talking about dermoscopy alone. If you have any questions, I'm happy to answer them. This is me in my last day of my Harvard fellowship, and this is me my last day at my Mohs fellowship at Sloan Kettering in New York. So.
يعطيك العافية والله يا دكتور سعود، ما شاء الله تبارك الله، ترى أحلى محاضرة كتير سواء ما شاء الله حضرتها من جد والله. وأحس دائما كذا إنه عندي deficiency في الموضوع، أحس إنه ما شاء الله اليوم يعني والله الله يديك العافية.